Okay, so we're going to move on to discuss some areas of concern that we know were fed back to us before the webinar and that we're hearing from the ground. One of them is around access. So Elliot, I'm going to ask you to help us understand this a little bit more. So the contract letter states that anything that's clinically considered urgent must be dealt with on the same day. But what does that actually mean? Because we're all very concerned, aren't we, about how we're going to manage this when we have finite capacity and we can't turn off the online consultations or ask people to call back. What are your views? What can you tell us on this?
Thanks very much, Lisa, and you're quite right. It's a huge concern for all of us in practice. And just on this links into the safe practice, and some people may be aware, but you and I did a little bit of a webinar on this about 18 months ago, which can still be viewed on the London-wide NMC's website, and I would recommend people view that as well. But thinking about this year, so, you know, as GPs, we have a duty to provide safe care, and also to look after our own staff well-being, and having uncapped demand just feels that it's counterintuitive to that type of principle. So we have to, when we're thinking about this, we have to think about what does actually deal with or dealt with on the same day mean, because that's what the contract letter is saying. So we come back to the old thing about words means what words say. And so to deal with it on the same day is the need for me to make a clinical assessment on the basis of the information I have. So this may be from the online consultation, it may have been received by the call that the person put through in the message from the reception team. It could be from somebody else that you've got this information from. And on the basis of that information, I then, if I've deemed it urgent, I need to take action. And that doesn't mean a face-to-face consultation with the person. And actually, if I deem that that person does need a face-to-face, but I don't have the capacity, then I would need to refer them or direct them onto another service. And people have been challenging whether or not this is right or not. But actually, when we look at the GMS regulations, which is what we always need to come back to, it states it is. And for those of you that like detail, well, look up Schedule 3, Paragraph 4, Clause 2C, and you'll find it. And what that actually says is that we need to invite the patient to make use of or direct the patient towards appropriate services which are available to the patient, including services which the patient may access themselves. So if you're challenged on that, that's where it comes from. It's in the regulations. But this is after adequate triage. So another important thing in that is that the little d in that same clause, which says that if you haven't got enough information, you can go back to the patient and ask more information. So if you've got, you know, what I frequently see an online consultation that just says abdo pain or something like that, I can't make an assessment on that. So it's perfectly reasonable to go back, get the information you need, and then determine whether or not that is urgent for the same day. And if it is, then if you can see them, if you've got capacity, see them, but if not, advise the patient appropriately. What we can't do is just have automated processes redirecting them to. So in the past, in my own practice, we had a telephone message that said, we're at capacity. If you think it's urgent, please contact 111. We can't do that sort of thing anymore, but it doesn't stop us redirecting. So Lisa, I hope people will find that helpful. Clearly, we're waiting for more information on all of this. So that's looked at that, but I'm going to now ask you a question, because actually we've had a lot of queries about the mandatory use of advice and guidance or single point of access, and it seems to just constantly be changing, and it's really hard to actually understand what's going on. So are you able to provide any clarity, thinking sort of from your regional viewpoint or national viewpoint?
Yes, thanks, Elliot. It's true, isn't it? We have had shifting national policy and acronyms regarding this, from advice and guidance to advice and refer, and now to single point of access, SPOA. This does seem to be moving quickly, but the national messaging seems to have softened. So we know GPs have many concerns about this, including unsafe rejections and deflections of referrals, workload and increased clinical risk being pushed into general practice, and loss of autonomy of and respect for GP expertise. In their publication last week, NHS England tell us that the SPOA isn't about rejecting referrals and there are no deflection targets. Previously, there had been lots of talk around 25%. And they also state that thresholds haven't changed and that GP judgment remains central. But capacity and financial pressures do and will affect what happens to our patients. We all know the reality will be local variation and inconsistency, both between and within hospitals, and there are a plethora of different complex reasons for that. But this is where LMCs and London-wide LMCs have a critical role in mitigating the risks. We will ensure GP voices shape how these pathways actually function. We will be actively representing GPs in the co-design of these pathways at both trust and London levels. In fact, LMCs already work with each trust through regular interface meeting where specific pathway issues are challenged, and in some areas of London, for some specialties, we already have some good experiences of working with our secondary care colleagues on these types of programmes. The London-wide LMCs work at the pan-London level in interface meetings and other regional forums will continue, and this is where we escalate themes, we share good practice, we call out where systems are unsafe or inequitable. We will continue to challenge inappropriate workload and risk transfer. We will continue to push back where thresholds are creeping up in practice, and we will hold systems to account where patient access is being compromised. And where issues are nationally driven and can't be resolved at the London level, we will still act. We will advocate for GPs so GPs can deliver safe, effective care. And we do that through engaging with MPs, national bodies, key partners and allies, ensuring that the impacts are properly understood and challenged. But at the same time, there are opportunities here if this is done properly.
Opportunities, you feel, really?
Yeah, I mean, I can't tell you how realistic this is in the current NHS context. But done well, a SPOA could mean that you don't have to second guess the exact service to refer to from a list which is out of date, only to have the referral bounce back. And potentially it could enable true consultant clinical triage with more nuanced weights rather than the choices we faced, which can feel like urgent or wait for an unknown period of months to years. It should also give us much better data on true demand for specialist services. And that matters because putting that alongside the wider drive to move care closer to the community, this potentially could create an opportunity to properly commission tier 2 services at scale in the community, for example, led by GPRs. And it could help us to rebuild some of those models similar to the gypsy services many of us remember from the noughties before local funding was withdrawn. And we had lots of positive experiences of those services, of having a community-based service, having better relationships where we could have conversations about patients. And it did, in some areas, bring us much closer, that interface between primary and secondary care, much closer and became much more collaborative. It could go a little way into supporting that type of more meaningful collaboration, rather than the very fragmented transactional one-way interactions that we have now. But none of that will happen by default. In addition to political will, it will require active design, challenge and ongoing engagement. And that's where LMCs will also need to focus their efforts. So we do want and need GPs to keep feeding back their experiences as this progresses, good and bad, so that we can represent and advocate effectively at all levels. We need to know what's going on so that we can raise it, challenge it, and work to fix it across London. So I hope that helps a little bit around advice and guidance and the SPOA element. Elliot, I've got a final question for you, though.
Yep.
There seems to be a lot coming out about the need to code all appointments, and that this is changing. Can you provide some clarity on this?
I will try, that's for sure. So for some time now, practices have needed to be aware about how they code their appointments. It was brought in 2021 with the PCNDES, and at the time we did produce a guide which is on the website and will be updated taking into account this year's changes. So the key change about this year is about the monitoring. So you need to know what's being monitored. So they're monitoring the call waiting times, that's throughout core hours, but specifically from 8 a.m. to 10 a.m. They're looking at the percentage of clinically urgent patients seen on the same day and the percentage of non-clinically urgent patients seen within 7 and 14 days. Of course, this is all retrospective monitoring of the data, and I know that query came up. But it's the way in which they're calculating this which is key, because they can't actually just directly go, that's the percentage clinically urgent seen on the same day. So what they're having to look at is look at those appointments that are coded as general consultation acute, and then look at the time from booking. So by looking at how far in advance they're booked, so it's on the same day, that's how they're getting that data. And this is important for people to understand, because that same day is there's a percentage of the ones that are coded as general consultation acute. So what that means for practices is that if they aren't correctly using the general acute consultation coding, it's not going to be picked up by the national data. So if you think about those appointments that sometimes they were advanced booking but weren't used and then suddenly use them from the day, if you don't change that type of consultation, it's not going to be put up for these. So you're going to miss those type of things. So when you are changing the use of a consultation from a pre-bookable to an on the day or vice versa, you need to adjust this. So equally with the 7 and 14 day appointments, which is the other thing they're looking at, what their category they're looking at is general consultation routine. So again, you need to make sure any of those booked at 7 and 14 day in advance are coded as general consultation routine, and the time from booking is the other thing they're looking at in there. Now, the problem with this is that a lot of us are doing digital triage, and what we need to be careful to do that if we are triaging that doesn't actually result in any contact with the patient, be that electronically, by the phone or in person, then we shouldn't be recording that as a consultation. And I know some practices that have fallen into difficulty because of that. We also need to recognise there is an awful lot of work that they are not capturing. So, all the nurse appointments do with long-term conditions and all that sort of thing, the clinical admin work, the MDT one, the home visits, that's not being captured. And I think the reason for that is a lot of the motivation behind this is the clinical headline about we are getting rid of the 8 a.m. scramble. So we need to bear that in mind and really be carefully looking at how we're coding these. And know and understand your data. So you can look at the GPAD website directly. It's a month in arrears, it's actually slightly longer, but there's some other really helpful resources that you can look at to actually help you with that. One of which I personally have been using recently is CAIP.app, APP, and that gives a lovely breakdown of appointment, telephone calls, including the missed calls, that type of thing, your online appointments, your online consultation and all your appointments as well. So utilise the digital teams that you've got to help you, but the first starting point of all of this must be that you go back and just double check that you're using the right codes for this, because you know what's being monitored. So I hope that's helpful, and I hope that clarifies some of the point, Lisa.